Welcome to Breaking the Couch, a weekly conversation demystifying what happens in and behind the therapy scene to support your healing journey. We're your hosts.
I'm Dr. Dowdson, a licensed clinical professional counselor, a certified school psychologist, and a trauma specialist with Playfully Psyched.
And I'm Dr. Jo Harchi with Soft Art Psychology, a licensed clinical psychologist.
We're here aiming to provide you with mental health tools to address the cycle of generational trauma across the age span, from infancy and childhood to adulthood.
For more information, visit our Instagram page at Breaking the Couch or our website, breakingthecouch.com. While we hope you love listening to and learning from our podcast, it's not a substitute for a relationship with a licensed mental health professional.
Right. So today we're back talking about some of the medical traumas that people can experience and just talking a little bit about how that can impact mental health. Sound good?
Yeah, sounds really important. I'm happy that we're able to touch all the bases of some of the main categories of traumas. Mm-hmm.
Absolutely. So one of the things that I don't think we've really talked about too much on this podcast is that we both have a medical background as far as mental health, right? So we've both worked in several hospital systems, worked in a lot of different units in the hospital system. So I was in the NICU, or the neonatal intensive care unit. I was also in the CVICU, or the cardiovascular intensive care unit, and then the maternity unit in some hospitals and a few other places, but those are my main focus areas. And then you want to talk about what you've done?
Yeah, I can't believe we haven't even brought that up. I'm super missing some of that work because I would do what they call consultations or consults, and it's like where you go bedside and let's say the person has cancer or spinal cord injury or was unfortunately in an accident, right? You go to their bedside and you kind of help them with some of their mood, or maybe if they, for example, are intubated and can't communicate with their team in ways that they would normally be able to, helping them sort of communicate and bridge with their team so that they get their needs met. So a lot of stuff around like mood, communication, helping them to feel supported in the moment. Certainly medical trauma work is done in all of that. So I've had some experience in hospital systems with consults, both outpatient where you go to the place and see them, or inpatient where I come see you, and a lot of stuff with children and teens around that. Yeah.
Absolutely. Yep. And so with that, like you're saying, I think one of the things that people don't really realize is sometimes you can have a medical procedure that isn't even like a major car accident, which we know, for example, a major car accident could have its own, you could walk away from that, or, leave that accident completely uninjured and still have PTSD or acute stress disorder. So still have trauma symptoms. And you can also go into certain procedures, medical procedures that are, putting your brain in that fight, flight, or freeze, making you think that it's life or death, or there might actually be life or death. And then you might have some of those trauma symptoms from that, right? And just when we think about, some people have a natural fear of needles, right? Some people develop a fear of needles because they've had so many, surgical procedures or things that have happened, and sometimes they don't go quite according to plan. And so then, as you're saying, sometimes the team will request a psych consult or psych consultation, sort of a psychology or psychiatry department to come and just give some additional supports to help assess the situation, make sure that, try to make that as smooth as possible. And that would be inpatient usually. And then sometimes there needs to be follow-up, right, into that outpatient world. One of the things that, in working in the NICU, the neonatal intensive care unit, that I really loved is that even though the baby, right, the neonate or the baby was my patient, I didn't have a patient, honestly, that was a lot of the family care work, right? And so we're really checking in on the families, checking in on their caregivers, and making sure that they're able to show up and be there for their baby so their baby can have a quicker recovery process, or a more smooth time while in the NICU. And, NICU consults are growing in popularity, but they're still far not enough NICU psychologists and NICU mental health workers working in hospitals or even consulting with hospitals. So it's a field that actually needs some help and support. And we would do screening for the parents for anxiety, depression, and trauma. So looking at PTSD symptoms or acute stress disorder symptoms. And they say the difference. So acute stress disorder typically are going to be very similar to the PTSD symptoms. Only acute stress disorder, you're only having those symptoms for like the first 3 weeks post incident, whatever the incident or catalyst was, whereas PTSD is going to be showing up a month or longer. Right. And for the initial phases when we're coming into the NICU, we're not yet looking at PTSD. And sometimes we can help, curtail that and to make it not go into PTSD. But it really depends on the family, their history, how long the child is in the NICU, right? Something I think that would be really helpful while I'm on this NICU path, and then I'll stop.
No, I think it's super helpful, and I'm happy you broke down acute stress disorder versus PTSD because I know that sometimes I'll say things on here and forget that people might not know the difference, and I think that could be helpful for people. There might be like an acute reaction that somebody has to a trauma, and then months later they don't have it, and so it wouldn't be PTSD at that point. So.
But one of the things I think it's okay really important for you to know and to think about is when I worked in the NICU, often people would say, like sometimes physicians or nurses or other people part of the care team, they would be like shocked when we'd say, oh yeah, this family is experiencing significant levels of distress. We also obviously wouldn't give a full diagnosis, but would say, hey, this is what is happening and we're supporting family through this so this baby can have a smooth time and as smooth time as possible in the NICU. But they would say like, oh, but this baby's just a grower and a feeder, right? So what that means is that the baby's in the NICU just until they can gain enough weight and need to eat a little bit more, and then they could be released. But there aren't significant medical complications, and it's just they don't release. Most hospitals don't release babies until they're at least 4 pounds, or unless they can pass the car seat test, which is basically they can fit comfortably in a car seat, because they have to be able to safely release the child from the hospital and know that they're going to reasonably get to their destination. And so they'd say, they're just a grower and a feeder.
This can't have been, exacerbating any old traumas. This can't possibly create any acute distress. No.
Yeah, like, no, their child is going to be fine. They just got to eat a little bit.
Of course it could still be traumatic.
But some of them would be so totally shocked, and they would say to the family, like, oh yeah, like they'll just be here for a few weeks until they like gain some ounces or whatever. And they just didn't always understand that the parents would be, really scared. And so, whether you're a parent of a NICU parent or you know someone, that's not helpful to put just in front of your child is in the intensive care unit. Oh, they just need they'll be fine. That's not helpful. Because a lot of times, again, what the research shows us is that it actually doesn't matter the severity of the medical issue that's happening. There's no correlation between medical severity and acute stress disorder or PTSD. So because what we're saying, oh, this is medically like not a big deal, or it's like minor, right? As Dr. Doherty were just saying, right? We're not assessing whether or not it triggered something else, right? And whether they had underlying anxiety anyway, and now it's through the roof because now they're having all these intrusive thoughts about all the horrible things that could happen, right? We don't know in that moment if they lost someone else in the ICU, right? Maybe it was a grandparent or parent, it could be anyone, right? They've had a prior experience, and so this is they're being triggered and they're back in that moment. We haven't considered, well, most people don't plan for their child to go to an intensive care unit at all, let alone like right at birth or whatever, right? And so that in of itself could lead to so many feelings, I failed my baby, I'm a poor parent, this is all my fault, anger, sadness, frustration, so many things can come up, and it is not directly correlated to, oh, your baby's just a throw in feeder and they'll be fine. Like, well, there could be already, a mental health disorder that is underlying that was unresolved or undiagnosed. and this is the catalyst that brings it out, right? And so having that care and compassion is necessary, and then having qualified mental health people in those settings is vital.
Yeah, and you're really making me miss the like almost like a cultural translation from the medical system to the human and vice versa, right?
Mhm.
Because that's kind of what we as psychologists do or did in those spaces.
Mhm.
And there's so many of these like problematic misunderstandings of like dismissing the person's stuff if we miss out on the psychological, psyche, spiritual, emotional components of how these things can affect people. And that was some of my favorite work too. Like for example, on the spinal cord injury unit, one of my favorite things was like we don't break down fences as Dr. Dotson and I have talked about. We don't sort of break down these defenses of denial. Right. A lot of times we would see people acutely in their spinal cord injury and they would experience some distance from how that might affect them. And we didn't mess with that. You know, we sent them kindness. We came to their bedside. We were helpful with like that sort of translation piece with their team. Is there
Mhm.
anything that they need right now that they're not able to communicate or that the team isn't hearing?
Mhm.
Right? And so that was like the biggest help as opposed to being like, no, you need to know that this is what's going to happen with you and blah, blah, blah. Like they've already been told those things. Give them a beat to like let it sink in, or maybe, you know, it happens later. And maybe that denial is a protection. And who the heck am I to knock down someone's protection?
Mhm. Especially without knowing if there's there's something else that could be erected,
I don't
right?
know. Yeah.
Or it's something else that you're
I
just
have
going to leave
no
them
clue.
defenseless.
I do not know.
Like,
Yes.
mhm.
And so yeah, that piece of like helping teams to kind of understand, and a lot of the nurses and the docs wanted to know, right? Like they were like oftentimes like mind blown by some of the, oh, you know, this person is intubated, for example, and wants to be telling you these things, and you know, you see her as very nice, and she is. And she also has a lot more to be telling you. And they're like, oh my gosh, I wanted to know that. Yeah, like I will check in with her. We'll come up with like a writing system and blah, blah, blah. So it's kind of this piece of we don't know what we don't know. And so if we kind of slow it down with the therapist coming in and assessing if there's some other better way for them to feel heard, it could be super helpful. And then for them to hear that, you know, you do have symptoms of PTSD or you do have symptoms of acute stress disorder can also be a huge channel to getting therapy started, to getting support, to just knowing. We know that just the label can be so helpful. So just knowing, oh, this is a thing. These nightmares, these intrusive thoughts, my avoidance of this situation
Yeah.
is a thing. Like I am valid in experiencing this distress.
Mhm, mhm. I love that, right? And sometimes one of the things that I would enjoy, so, you know, kind of being in the NICU space, we did, you know, I served parents and families of all genders, right, all backgrounds. And sometimes, specifically like fathers, would say things like, just focus on my partner, or just focus on the mom, what have you, or I'll be fine. Or I'm not feeling it. Not like I'm not feeling anything, because obviously I'm scared, I want my child, whatever, but like, you know, they would be dismissive of their own possible what could come up for them. But what we know in the research, right, is sometimes just giving people like this is what you could experience even when going home. Because actually what the data shows is that fathers, particularly, when a baby leaves the NICU. So typically you're discharged from the NICU and you're healthier. The baby's healthier. Like everything's going okay medically. And so they're being discharged home. And uh, sometimes, you know, moms, uh, sometimes it's moms specifically, their anxiety might go up a little bit, like as soon as right at discharge, because like, oh my gosh, now I have to be home and have to do all the things, but there used to be monitors to make sure we knew things were going okay, and they're having all these like elevated, you know, worry thoughts. But with typically with fathers, it's like 6 months later. 6 weeks to 6 months later,
I didn't
where
know that.
that's when they spike, right?
Mm,
And part of that can be because, uh, you know, now they're like, oh, I can, like they have spent all their time on with their partner, right? And like kind of focusing on whatever. And they were just like, let me go to work, let me do these things, like let me like keep all the other parts of our life kind of stable.
mhm,
And then they're in that when their things look like they're better medically for baby and everything's happening and she's kind of been settled back home. Now their system is kind of breaking down, like
mm,
realizing all of the stress and realizing all the things. It's like that toxic stress build up. But it's such an
mm,
interesting thing because sometimes even just letting them know, like, okay, well, if you start to experience irritability in a few weeks, right? If you start to notice you're feeling more tired, well, we kind of go through some of these things. You might want to just check in with it with your physician, see if you can do even a screener, talk to someone, come back to us, right? Because you are susceptible to this. This is possible for
mhm.
you. And we just know that sometimes with some families, it's a little bit delayed, depending on how your roles are set up, right? And so the data has been on men and women. But really, I think it's also has a lot to do with the roles that people will take on within their relationships, caregiving roles, and what that looks like, and who is responsible for what. So that piece, right? Just knowing that, oh, this is possible. One,
Mhm.
takes a stigma out of asking for help because we kind of already laid the groundwork. Like this might happen. If it happens, contact us. Let us know. Or here's some resources for you. Um, I think it's really helpful for people to just be like, okay, all right, it's good to know what could happen, and if it does, I have these resources to be able to access.
Yeah, so then they're going through their wallet, like, "Where's the business card for Dr. Doughton? I remember her," like
Mm-hmm, mm-hmm,
yeah, absolutely, and just to know that you're not alone and this is a thing, like, you're
mm-hmm.
not over here in La La Land with this, like, it's an
Yeah,
actual thing, yeah.
yeah. And I think um, especially for thinking about like biological families. So I was like, it's biological families and adoptive families,
Mhm,
but when you're not the person who physically carried the child,
mhm,
right? Sometimes you suppress your feelings, your emotions,
mm,
and don't really realize you're doing it because there's a feeling of like, well, I'm not going through it as bad as XYZ because I didn't even carry the child, right?
mm,
And that's not what the data shows. The data that shows that psychologically, your mind, your emotions don't care who carried the child. You can still have all these same symptoms, and it's okay. And you need to know that that's possible, and not feel weird or bad about that if that's something that you're experiencing. Right? There's help and
mhm,
support because medical trauma is real.
mhm. It is, and I hope that if you wanna know more about medical trauma, you can reach out to us and let us know. As we wrap up, I'll say that I think in the grand scheme of things, we're just introducing the concept that medical trauma is a thing because so few people know about it, and how if you've had a surgery or you've, survived cancer, there's some medical component, to your healing journey, and it feels triggering,
Mhm.
like, you might look into that, and I hope we just validated that that's a thing, and just let us know if you want to hear more.
Absolutely. So, and if you do want to know more, we're on Instagram at Breaking the Couch. We have a website. You can fill out a survey, breakingthecouch.com. Let us know. You can, give us your free open responses to say, hey, we want to learn more about this. Or I have this question. Free to do that. Tag us in your stories. Leave a comment on where you watch this video if you watch it on the video format. And you can also call in and leave a voicemail. And then just a little shameless plug. I am going to be part of a NICU summit. I just thought about this. I was like, oh, I should probably talk about it. I'm going to be part of
Go
a
for it.
NICU
Yeah.
summit. And I'm just going to be doing a little basic NICU for mental health 101.
Ooh,
It's targeted towards like nurses and physicians and just to know what our role is in the NICU. That's going to be through PESI. And if you ask me what PESI stands for, I do not know, but I know it's PESI. I don't remember it, but PESI. You can look it up online and we'll make sure that we put a link to that in our show notes. Until next time.
If you are looking for a therapist for yourself or your child, you can visit our websites, playfullypsych.com or softheartpsychology.com.
We appreciate you joining us this week and can't wait till there's another opportunity to jump on the couch with you next week.